Speaker Dr. LekhaT, Senior Consultant UVA and Medical Retina, Giridhar Eye Hospital. Ma'am will be speaking on challenges in imaging in uveitis.
Good morning, everyone, and thank you, Dr. Neetu. So, after that, two excellent talks, this is just my effort to know the importance of imaging in uveitis. So, as we all know, imaging has become a core component in the evaluation, management, and monitoring of uveitic conditions. And these different modalities of imaging give us a lot of complementary information and serve as building blocks in the diagnosis and follow-up. However, sometimes imaging can be challenging when you are not sure as to when to do the imaging and which imaging modality that we have to choose, how to interpret the findings, and also correlate with its clinical features. We'll go through some case examples. So this is a 37-year-old healthy male on treatment for recurrent anterior uveitis with cystoid macular edema in the left eye for many months. His workup was negative. When he came to us also, he had non-granulomatous anterior uveitis and significant cystoid macular edema. So because of the multiple recurrences, we thought we'll just do an imaging, and digital fluorescein angiography revealed not only the hot disk and perifoveal leaks, but also diffuse capillaritis in all the quadrants, and subsequent workup showed that he is HLA-B51 positive and he could be stabilized with appropriate immunosuppressive therapy, and he remained stable over time. So the challenge was in the decision making, because many times when the findings are predominantly in the anterior segment, we may not actually proceed with the detailed imaging, but DFA has a role in any case of very severe, atypical or recurrent anterior uveitis, or those cases with CME, because information that we get from the imaging enable more accurate characterization of uveitis. And ultra wide field DFA is especially useful in picking up vascular leakage, not only in active uveitis but also in inactive uveitis and in eyes with CME. So this is a 9-year-old boy who's been having severe non-granulomatous anterior uveitis, 3+ cells, not responding to topical medications. Fundus and OCT was normal, workup negative, and with the difficulty we could convince the parents, and in his case also DFA showed extensive capillaritis with fern-like leakage, and finally he required biologicals for stabilization. So in pediatric uveitis also, the fundus imagings can be very subtle, and activity on DFA is an indication for systemic therapy. This is a 61-year-old lady who was referred to us by the rheumatologist, and she had only mild anterior uveitis with occasional cells. Fundus was also grossly normal, but she had blood reports which showed that AC was raised and Manto was negative. So we decided to go ahead with dual DFA and ICGA. DFA showed hot disk and perifoveal leaks, whereas ICGA showed multiple hypodense lesions suggestive of occult choroidal granulomas, and further workup led us to a diagnosis of sarcoidosis, and she could be stabilized with immunosuppressive therapy. So whenever a choroidal pathology is suspected, a DFA alone is not enough. It has to be combined with ICG angiography also. This is a young male doing his engineering. He's been having poor vision for 10 years, undergone multiple treatment. All his uveitic workup was negative. When he came to us, he had chronic anterior uveitis with posterior synechiae and small pupil. Fundus examination was not possible, no view. So normally in such cases, we do a B scan. B scan showed an unexpected disc drusen in both eyes and mild RCS thickening. But don't stop there. We tried our optos, which gave us an information that there is no major pathology in the fundus except for the disc elevation, and though a hazy image OCT macula showed that there was a foveal contour was normal, but then we proceeded with DFA, which showed hot disk and diffuse capillaritis, which enabled us to start a systemic therapy, and he has been remaining stable. So even in small pupil, if you have the facility for confocal imaging, it will give you a lot of information, because here the reflected light is very narrow. It is captured through a small confocal aperture, and all the other scattered light is suppressed, which gives you a very clear image in small pupil. And this is the same principle that is utilized in optos wide field imaging, which can give you almost 200-degree view of the retina through a small pupil. So don't ever give up in patients with small pupil and chronic uveitis. This is a young male who noticed defective vision since 1 week. He consulted a local doctor who was prescribed glasses with myopia correction, but he was not happy with that. When he came to us, he had very shallow anterior chamber, slightly raised IOP, closed angles, and ciliocoroidal effusion on ubium. So normally, what do you think? Though he had a past history of migraine, he was not on any treatment recently. So our first possibility of drug-induced angle closure could not be convinced because there was no positive drug history. The other possibility was a VKH, but his fundus and OCT was normal. However, his multicolor imaging showed significant ILM folds over the macula, so we decided to wait, and 1 week later when he came, the fluid had already started, and OCT helped us to confirm the diagnosis of VKH. So here the problem was the patient presented in the very early course of the disease. So the same confusion can happen when it is too late also, when already more structural alterations would have happened, either due to scarring or pigmentation. This is a 44-year-old male who's been having defective vision for 2 years, undergone multiple treatment, TB ruled out. Vision was quite affected with 660 in one eye and counting fingers in the other eye. He had non-granulomatous anterior uveitis and also vitritis, and for other fundus changes could not be made out very well because of the hazy view. So intermediate uveitis was considered and we proceeded with the workup. DFA again was little difficult to interpret because the images were not clear. Some kind of mixed hyper pattern was there and little bit of diffuse capillaritis. OCT showed intraretinal fluid, hyperreflective lesions in the outer retina and significant EZ loss. So what are we looking at? I was finding it a little difficult to come to one diagnosis. Anyway, all his workup turned out to be negative, so we gave a trial of oral steroids, and when he came 1 month later, the fundus view was better, which revealed little more pigmentary changes, but it was delineated much better on autofluorescence, which gave us a diagnosis of pigmented paravenous retinochoroidal atrophy. And further workup, including ERG, showed the reduced photopic and scotopic response. So here the challenge was because of multiple pathologies, and we were unaware of the pre-existent undetected retinal pathology, and the coexisting inflammation was interfering with the visualization. So please remember, uveitis can contribute to the pathogenesis, and it can be the initial manifestation of these kind of retinal dystrophies. So in any patient with indolent uveitis, RP or its variant should be suspected and ruled out by MMI. This is my last case, 61-year-old male who has been having defective vision for the last few months, already undergone anti-VEGF injections and PRP in one eye, and he was also treated for inflammation elsewhere with periocular and systemic steroids. Systemic history revealed diabetes, hypertension, CKD and HIV, and he was on ART. His recent CD4 count was good and viral load was not significant. On examination, vision was counting fingers in the right eye, 6/9 in the left eye, anterior segment was quiet. Fundus showed PRP scars in the right eye and hard X-rays near the fovea, and left eye had moderate NPDR. Autofluorescence showed some patchy hyperfluorescence around the fovea only in the right eye. However, OCT showed significant intraretinal fluid, subretinal fluid, hyperreflective irregular RP, pachychoroid, and also in the left eye something like a choroidal granuloma. Again, it was a very confusing picture. Other OCT scans showed significant RP undulations and SRF in both eyes. RNFL edema was also there in both eyes. So what are the possibilities? Definitely he has diabetic retinopathy, but along with that, is it VKH or some posterior uveitis with a choroidal granuloma? Is it HIV related, or is it a chronic CSR or some kind of masquerade? Yeah, so we proceeded with further workup. In the meantime, we thought let him continue the steroids. At 1 week, we thought maybe he's improving, but by 3 weeks, he was definitely worsening with increase in the retinal fluid. All his blood workup turned out to be negative. We did his DFA, which was again difficult to interpret. Diabetic retinopathy changes were there. Along with that, there were diffuse window defects, then the blocked fluorescence due to the laser scar. So it was all creating a lot of confusion. But a little more careful evaluation showed focal RP leak in the right eye as well as in the left eye, revealing a diagnosis of CSR. So here the problem was because of multiple ocular and systemic pathologies, and also it was a lasered eye which was all creating difficulty in the interpretation. And remember, CSR is an important differential diagnosis of VKH, and we should always need MMI for confirmation. So whenever the findings are atypical, remember to rule out masquerades. Thank you.
Thank you, ma'am. Thank you for this very informative talk. And it was a beautiful collection of cases and